Hey gang, so this week we are reading chapter 6 in your text about caring for patients. And in this chapter, there are kind of three main ideas. When we think about caring for patients, we need to consider how patients experience illness. We also need to consider what the relationship is between what your book calls medical good versus total good, and spirituality and how that can play a part into a patient's overall well-being. So we are, as PTAs, we're walking a line between the art of caring and the science of healing. To be a caring professional, caring for patients relies on the principle of beneficence, which is the moral requirement to promote the well-being of patients. So the ethics behind a caring response. A caring response indicates certain responsibilities that we have as the professional. A professional caring response is sometimes identical to the one you would show towards a friend or a relative. However, a health professional's relationships are very different. We have moral and legal dimensions that are not fully applicable to other relationships. It's critical that we as professionals avoid crossing boundaries. So clinically, ethically, we have responsibilities. We also need to consider the professional standards of due care. Your text talks about due care in chapters 2 and 3. Due care is a legal term used to specify the essentials expected of you in a given situation, like your professional competence in your role as a provider of a professional service. So that means we need to use reasonable caution when we're formulating relationships with patients. And then some principles of a caring response. We've talked about these already, but again, by definition, beneficence is the quality or state of doing good or producing good. Non-maleficence is, first do no harm, not harming or inflicting the least amount of harm possible to reach a beneficial outcome. And professional duty is that we need to act in a professional manner to obey the law. We need to avoid conflicts of interest, and we need to put the interests of the client ahead of our own interests. So all of these play in as we are giving the patient our best caring response. So let's look at a few fundamental concepts that come into play as we're talking about exactly what is a caring response to our patients. I think we kind of know this at a gut level. And again, it's one of those things kind of hard to put into words, stuff we just sort of automatically do. But nurturance is the human social behavior of supplying material and emotional support to meet the needs of whoever's helpless, meet the needs of the helpless, the young, or the weak. We want to make sure that the patient is the primary focus of our loyalty, even more so than our employer. But at the same time, we need to have appropriate boundaries that will help protect us ultimately and help protect our patients. For example, we don't want to care too much. Patients are vulnerable when they are experiencing a health-related issue, so we create some boundaries guided by that vulnerability. We also need to recognize that caring is, of course, part of our professional duty. Physical therapy is a caring profession, right? In your text, starting on page 81, there's an example of the little boy, Alan McMurdy, who was diagnosed when he was 8 years old with muscular dystrophy. And that example talks about how care must be individualized. Also talks about how providing care for patients requires listening to them, engaging them as participants, and respecting their autonomy. Listening can be, so individualized care, listening to your patient can be, the very key, can be integral to treating them. You're doing all those different levels of listening that we talked about way back in 101. You're trying to pick out what are their concerns, what are their fears, their anxieties about pain, any anxieties they have about recovery maybe, or even loss. And we're giving them specialized care related to them specifically and how they experience illness. It's very personal, very individual, and very specific. So some components of a caring response. When someone's ill, we're going to look at these 3 different components of caring, okay? So personal concern is the idea that people are more than just medical diagnoses and medical problems, okay? These kind of all 3 go together. Patients often feel threatened by any change in their physical function. So we can perhaps change their narrative they believe about their illness by our caring and our skilled response. Now, medical good versus total good. Again, going to the example in the text about Alan McMurtry, the 8-year-old with Duchenne's muscular dystrophy. There's a very interesting discussion. It's on page 81 and page 82. About this little boy. Who was diagnosed when he was little, and then talks about him later on too. There's a very interesting discussion on how to maintain the balance between a person's medical good and their total overall good. We'll get into defining those too. And spirituality is another component of a caring response when a person is ill. We need to have an awareness of and an acknowledgement of spirituality within our patients' lives. Play a really big role for some, maybe not so much for others. And also be aware of and acknowledge possible differences between their and maybe our own religious and spiritual beliefs. So empathy versus sympathy. I actually put I love this video. It's by Brene Brown. I put it in the module for you to watch, just the difference between the two. So empathy basically is understanding what others are feeling with a sympathetic response to them. So we have a cognitive understanding of what they are feeling. I could be you. I can see your pain and I understand it. Versus sympathy. Sympathy is an emotion of concern for others' difficulties and sharing of their problems. Like, I feel for you. I feel your pain and I feel your sorrow. So watch that video. I think it does a really nice job of highlighting the difference between empathy and sympathy. And compassion is, deep caring in response to suffering. I have compassion on you. I want to help you. Versus pity, this is like, oh boy, you need some help. So caring that includes looking down on the sufferer, kind of a I'm better than you attitude maybe. So okay, medical good and total good. All right, so medical good is this idea that a patient's well-being is measured in terms of health, versus total good, the idea that a patient's well-being is measured in terms of their overall life experience. So read that example in the text about page 81 and 82 for a good description of those. What do you think? Is it possible to meet both for all of our patients? Do we focus on their medical good and not be too involved with who they are overall as a person, their overall life experience? So likely the best resolution involves the caring practitioner who's considering both, and that's what they talk about in page 81 and page 82, that really it's wise to have obviously a patient's medical good in our forefront of our minds, but we also want to keep in mind who they are overall in life. What are the other things that are important to this patient? And maybe not just their diagnosis, yes? Now, spirituality. So finding meaning in life through a sense of self-transcendence, a sense of relatedness to something greater than the self, is the definition of spirituality, okay? Finding meaning in life through a sense of self-transcendence, a sense of relatedness to something greater than the self. This may or may not include religion. The holistic healthcare approach looks at mind, body, and spirit. So again, we need to respect individual choices with an awareness and an acknowledgement of spirituality within our patients' lives and possible differences between their and our own religious or spiritual beliefs. We're going to be aware of personal values and biases. It's good to become aware of the spiritual background of your patient and to incorporate a sensitivity to spiritual issues within your treatment plans, and also demonstrate the respect that different spiritual issues demand. So some challenges within a caring response that can kind of limit you. Maintaining professional distance, yes, that can be hard. Maintaining professional boundaries, having over relationships with patients. Maybe financial arrangements can challenge you to provide a caring response. Maybe you need to see X amount of patients per day to make your bonus. I don't know. And you're doing that on in a way that compromises your caring for patients. Challenging patients we'll talk about, and definitely it is easy to become burnt out when you are in a caring profession. So first up, professional distance, okay? Professional distance is the idea of not becoming inappropriately involved either emotionally or behaviorally with patients. We can be involved with patients too much. So in your text, they mention Kurzer. He, an author of a study, and your text quotes it quite a bit. It's on page 86. But he says that, and your text doesn't say they totally agree with all of his points, but he does bring up some good things to at least consider when we are involved in a caring profession. So, professional distance. Healthcare professionals should act as if they are significantly emotionally attached to their patients, but in fact they should involve their feelings relatively little. They should hug patients who need to be hugged, but they shouldn't really care. So how do you do that, like as a human being, right? So your text quotes, like by Kurzer, 5 or 6 different dangers, if you will, of caring. So first, Kurzer argues that forming emotional attachments, with a patient, maybe the patient doesn't want to be emotionally attached to you. So forming emotional attachments unwanted by the patients actually invades the patient's privacy. So, this would be like an inappropriate expression of emotion by the therapist to the patient. That can be considered an invasion of patient's privacy. Okay. Second, Kurzer argues that caring threatens a patient's autonomy if the professional pushes their own agenda or power rather than respecting the patient. Third, Kurzer says that healthcare professionals should be impartial as possible as they can be towards patients, because emotional investment in a patient invites bias and or favoritism. So we need to practice impartiality, which is critical for professionalism and maintaining professional distance. Fourth, because caring about patients might lead the PTA to seek out the best treatment for them. Doesn't sound bad, but he argues that this could lead to an eventual skew in the distribution of healthcare supplies, so you want to be aware of potential conflicts of interest. He also says that having emotional ties to patients tends to compromise our objectivity, which could threaten an accurate diagnosis and treatment decisions. Now, keep in mind, he's writing this towards like hospital professionals and doctors in the hospital, not necessarily towards a physical therapy audience, because I think that, physical therapy is definitely a caring profession. And also, he indicates that it's difficult to leave emotions behind at the end of the workday. So caring can lead to professional burnout. Yes, there are many things that can lead to burnout, including having caring relationships with patients. be aware of what else is going on, okay? I love this quote from your book. Yet, burnout is not solely or primarily due to patient contact. It comes largely from organizational structures and management that strip providers of a sense of control and purpose. It can also come from systematically stifling emotional responsiveness to patients who are the focus of one's professional life. So maybe productivity demands or patient overload. When I was in the clinic a lot, I could always tell when it was time for me to go on vacation. Maybe needed a little break from caring to patients all the time, yes? So professional boundaries are to maintain physical and emotional limits that are appropriate. And we maintain those while we are in the health professional, so PTA to patient relationship, okay? And the goal of these having professional boundaries is to facilitate a patient's well-being and to maintain respect in the interaction. So we want to avoid becoming inappropriately involved, either emotionally or behaviorally, with patients and others involved in your work, okay? We also want to manage our professional responsibilities, manage our emotions and our attitudes. There's this idea of over-distancing from a patient. You can be too far away or uninvolved, under-concerned, over-distance, if you will, from a patient. That may lead to having pity on a patient, or under distancing. When we think about boundaries, you want to be somewhere right between the two, I think. Under distancing is becoming too close, too involved. That can actually lead to compassion fatigue and maybe possible crossing of professional boundaries. So keeping in mind that patients are our patients as a professional, we should not form friendships with or socialize with patients while they are actively on our schedule. I would say that there have been times where I have actually gone out to lunch with a patient who, after she discharged. Now, was that the wisest decision? I think it's appropriate to use discretion after their discharge if you want to form friendships or socialize with a patient. What happens if they come back on your schedule for another time? It's definitely a gray area. So, and I would say too, use the same discretion regarding social media. Is it wise to become Facebook friends with a patient either before, during, or after treatment? Use discretion, always keeping in mind you have to maintain that professional boundary, okay? And so I just wanted to pull up, it's WAC 246-915-182, the rules about unprofessional conduct. So regarding dating or romantic relationships or even sexual relationships, here we go, WAC 246-915-182. The PT or PTA shall never engage in sexual contact or sexual activity with current clients. Sexual contact or sexual activity is prohibited with a former client for 2 years after cessation or termination of professional services. The PT/PTA shall never engage in sexual conduct or sexual activity with former clients if such contact or activity involves the abuse of the PT/PTA, so the therapist-client relationship. The PT or PTA shall never engage in sexually harassing or demeaning behavior with current or former clients. So be careful. Do not become involved with a patient. That is the best advice I could give you. Excuse me. So what about treating family? These rules, the WAC that I just read, don't prohibit the provision of physical therapy services on an urgent, unforeseen basis where the circumstances will not allow a PT or PTA to obtain reassignment or make an appropriate referral. The provision of PT services to a spouse or a family member or any other person who is in pre-existing established relationship with the PT or PTA where no evidence of abuse of the patient-client relationship exists. So again, the law doesn't explicitly prohibit it, but I would say it is one area where you have to be very careful, and you really want to think about your professional to client relationship, because you would have to be able to prove that there's no evidence of an abuse of that relationship, okay, if you are treating a family member. I personally wouldn't want to do it. I actually have declined seeing my brother-in-law was coming into the clinic that I was working at, and I was like, no, I don't want to see him. I love him, but no, I'm not going to do it. And that was my personal preference. All right, so the challenging patient, okay? Who is the difficult patient? Who is the challenging patient? That might vary for each of us based on our own attitudes, our own experience, and perhaps those biases that we either know or don't know we have, and we're working hard to keep those from influencing our treatment. So one of the things we used to talk about kind of behind the scenes in my clinic was, it was kind of a, I don't know, tongue-in-cheek. I don't want to say joke, because I think there was maybe some good truth to it, but anyway, we had our patient initial evaluation was colored on the schedule like dark blue when they're coming in. If the patient was a repeat patient on an initial evaluation, but they'd been a patient before, they were colored like lighter blue on the schedule. And then if a patient was due for a 5th visit or a 30-day reevaluation by the PT, we colored them green. So we had this different color coding thing on our schedule. So I used to say, man, we should have, for certain patients, we need to color those guys like pink or something, you know, those ones that you don't want to have too many of in one day, right? Because they drain you. And like, I was kind of kidding, but kind of not, because you almost need a little, you need some time to like prepare yourself to work with the challenging patient, then maybe decompress afterwards. Like, you really don't want to have too many of those people on your schedule in one day, right? But the reality is you likely do. So really, it's our attitudes about patients that can make a patient challenging. We need to look at, you know, maybe what we think about somebody in a different social class of us. Of course, we have to care for everyone. And here's the Code of Ethical Conduct Standard 1A. We need to act in a respectful manner towards each person, regardless of their age, their gender, their race, their nationality, their religion, their ethnicity, their social or economic status, their sexual orientation, health condition, or disability. So I listed just some of the things that might define who is a challenging patient to you, that may affect your attitude towards a patient. Again, we might call somebody, you know, coworker might think somebody was challenging to work with, and I might not, okay? Based on what we think about social class differences, different physical conditions or diagnosis, we could be maybe fearful. I actually used to be fairly fearful of working with amputee, okay, patient. We might consider a patient to be uncooperative, and that could be challenging. I don't know if there's certain psychological dysfunction, definitely that can be challenging to work with. And suicidal thoughts, you know, patient, that can be a hard patient to work with. Just a reminder that we are required, healthcare provider or healthcare facility may disclose healthcare information about a patient without the patient's authorization to the extent that the recipient needs to know the information. If this disclosure is to any person, if the healthcare provider or healthcare facility reasonably believes that the disclosure will avoid or minimize an imminent danger to the health or safety of the patient or any other individual. So basically that means we need to report it if a person is having suicidal thoughts. That's a lot of law to get out there. But yes, we are mandatory reporters in that case, all right? So we don't want a patient to harm themselves. So how do we maintain boundaries and manage burnout? So compassion fatigue is real. Like I said, I used to always kind of know when it was time for me to go on vacation. I've been without too much of my own time, I guess. So I can tell you, maintain a rich personal life. We talk about filling your own tank, filling yourself up before you can give out to others, right? Have good relationships, right? Maintain a rich personal life if you can. Know yourself. Know what triggers you. Know who you might consider to be a challenging patient, okay? I would say, too, it's important to communicate honestly with a patient, especially if they are a little bit challenging. Just be honest. Share your feelings with your coworkers. You know, coworkers can be a good support system. So when I talked about, coloring patients a certain color on the schedule, just sharing that I thought that with my coworkers felt good, right? That helped me think, okay, I can manage working with this patient, because other people kind of feel the same way too, right? Ask for somebody else's perspective, get their perspective on it. Also, guys, too, don't share too much about yourself. That's a big one about maintaining boundaries. Acknowledge a patient's feelings, and don't be afraid of a patient's emotions, but also be aware of your own limitations. Don't be worried about referring out if you need to. So if somebody is, say, like psychologically needing help, don't be afraid of their emotions, but be aware of your own limitations. So refer out when you need to. All right, gang, that is it for now.